Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. So welcome, everyone, and thank you for joining our Functional Medicine Discussion Group meeting. I'm Dr. Ben Weitz, and our topic for tonight is the prevention and reversal of Alzheimer's disease with our special guest, Dr. Dale Bredesen. I'll start by making some introductory remarks, including introducing the topic. So the topic for tonight is Alzheimer's disease. And as most of you know, it's a degenerative brain disease, and it accounts for between 60 and 80% of cases of dementia. Patients with Alzheimer's disease develop difficulties with memory, language, problem solving, other cognitive skills that affect a person's ability to perform everyday tasks. The hallmark pathologies of Alzheimer's are the progressive accumulation of beta amyloid protein in the brain that forms plaques outside neurons in the brain and twisted strands known as tangles of tau protein inside of neurons. There are an estimated 5.7 million Americans living with Alzheimer's disease as of 2018. Obviously, it's higher now because it's rapidly increasing, especially as the population of Americans 65 and older is projected to grow from 53 million in 2018 to 88 million by 2050. According to one estimate, Alzheimer's disease is the third leading cause of death in the US, according to the Alzheimer's Association. According to the Alzheimer's Association website, and this is a quote, "While there is no cure for Alzheimer's disease or a way to stop or slow its progression, there are drugs or non-drug options that may help treat symptoms. Our goal for this evening will be to prove that the Alzheimer's Association is wrong." Now I'd like to invite Heather No from Cyrex Labs, which is one of our sponsors for this evening, to give us some information about Cyrex Labs. Heather, are you here?
I am here. Thank you so much, Dr. Weitz. Hello, everyone. My name is Heather Sunshine, Territory Manager of Cyrex Labs. Our lab is based in Phoenix, Arizona, and our niche is environmentally induced autoimmunity. We are CLIA certified, and our innovative test provides advanced clinical tools to identify and measure immune and possible autoimmune reactivity. We have essential barrier testing evaluating the intestinal and blood-brain barrier integrity. We have predictive antibody testing, identifying markers and possible precursors of autoimmune disorders, environmental triggers, identifying reactivity to environmental triggers, which include dietary proteins, chemicals, and heavy metals. We also have a mucosal immune saliva test. But what I would like to share with you today, since it's relatable to Dr. Dale Bredesen's presentation, is our Alzheimer's links panel. Alzheimer's disease, cognitive decline, dementia, whatever name we use, the diagnosis is a heavy one. It comes with enormous financial and family burden. So ideally, you want to avoid this disorder. Environmental factors are far more influential than genes. And if it plays the larger role in Alzheimer's disease, we have the opportunity to prevent it. We change our environment. We avoid certain foods, chemicals. We reduce stress. We make our bodies inhospitable to pathogens. We learn a new language, take dance classes, play brain games to regenerate neuronal tissues. We can protect our blood-brain barriers. All of this means we are reducing inflammation. The subclinical signs of inflammation, antibody production against triggers and tissues can be found up to 20 years before the onset of disease. Therefore, in the more common form of environmentally induced Alzheimer's disease, the late onset, people should be tested as early as age 40. So here's how Cyrix is going beyond tau and amyloid beta. We assess proteins, growth factors, pathogens, chemicals, enteric nervous system, enzymes, neuropeptides, and foods. Alzheimer's links can be used to identify targeted tissues, triggers, and blood-brain barrier integrity during the early on stage of Alzheimer's disease when recovery is possible. So test at the first sign, especially if the patient has family history. We do have a video of Dr. Bredesen with our brilliant chief scientist advisor, Dr. Risto Vojdani, along with his brilliant son, Dr. Elroy Vojdani. And you can view this video on joincyrix.com. It's under our media section. And if you would like to schedule a one-on-one education or have any questions, if you want me to send you a catalog of services, we do have some new bundling prices and specials. Or if you just want me to send the link to the video, please email me at heather.s@cyrixlabs.com. Thank you so much, Dr. Weitz, for the opportunity to discuss Cyrix and providing us an insightful forum. As always, we are excited to listen to Dr. Bredesen's presentation tonight.
Thank you, Heather. And now my friend Steve Schneider from Integrative Therapeutics. Steve, you have the floor to tell us about Integrative Therapeutics professional line of supplements.
Well, so that was really good. I don't think I can do that well. But so one of the things I wanted to mention, Dr. Bredesen, was, by the way, I'm Steve from Integrative Therapeutics. Most of you know me already. I'm the LA rep for Integrative. But Dr. Bredesen mentioned Gary Small over at UCLA. They actually did a nice study on our Theracurmin, the high bioavailable curcumin, showing improved memory and decreased amyloid tangles and tau proteins. So it wasn't Alzheimer's patients, it was age-associated memory decline, but some pretty interesting outcomes, and they're continuing to look at that. So I don't know where that fits into your protocols, but it was a really good study for that particular product for us. And then the other thing I was just going to mention really quickly, some of you saw this on the Facebook page, but there's been a lot of chatter out there about NAC or NAC being banned. And I just wanted to kind of let people know that's not what's happening. The FDA sent out some warning letters last year, basically trying to say that NAC shouldn't be considered a supplement because it was originally researched as a drug back in the early 60s. So it's not a policy change. It's not anything kind of legal change. They're just sort of sending out these letters. The Council for Responsible Nutrition is pushing back on it pretty hard. There's a great letter you can Google that talks about it. It's also on Dr. Weitz's Facebook page. And the reason people are getting excited is because Amazon pulled the NAC containing products, and Whole Foods Market will probably follow that because they're owned by Amazon. We're not sure why they're doing that, but we are not discontinuing any NAC containing products. We don't think it's going to end up coming to that. It's business as usual. Right now, Fullscript has over 1,500 bottles of our product. We have about 8,000 bottles of our product. So it's not in short supply. If you need it, you can get it. The other thing is, if it ever does come to that, Integrative Therapeutics will still be able to make it because we are a drug manufacturing facility, even though we don't make drugs. So not every supplement company is that, and that will affect some people. But it won't affect us. So we will continue to make NAC. We have a standalone NAC that's 600 milligrams per cap. It's under $20 retail for 60 caps. It's a great option. So don't panic. Don't believe what you're reading. It's not getting banned. And if you have any questions, you can reach me at steve.snyder@integrativepro.com. Thanks.
Thanks, Steve.
Yeah.
So our speaker for tonight, who really needs no introduction, is Dr. Dale Bredesen. And Dr. Bredesen is an internationally recognized expert in the mechanisms of neurodegenerative diseases like Alzheimer's disease. He's the author of the best-selling books, The End of Alzheimer's and The End of Alzheimer's Program, as well as the soon-to-be published The First Survivors of Alzheimer's. I also wanted to let everyone know that Dr. Bredesen, Dr. Toups, and associates have just published a paper documenting their trial with 25 patients showing the effectiveness of his protocol for Alzheimer's disease. And the paper is entitled Precision Medicine Approach to Alzheimer's Disease, Successful Proof of Concept Trial. And Dr. Toups posted it on the Facebook page, so you can get a full copy of it there. And I'd like to tell you one more quick anecdotal story. I've been organizing these functional medicine meetings for about 5 years. And about 4 years ago, I decided I wanted to discuss Alzheimer's disease. And I tried to get in touch with Dr. Bredesen because I had heard him a few years earlier on Dr. Bland's Functional Medicine Update audio show to see if he could join us. But I was not successful, so I sent out a copy of Dr. Bredesen's 2014 paper to our members to use as the basis for our discussion. Then I contacted the UCLA Alzheimer's program that Dr. Bredesen was associated with to see if perhaps another neurologist might want to join us. And when I called, the woman who was the administrator of the program said that she would ask around the neurologists there, but she let me know right up front that they don't agree with anything that Dr. Bredesen talks about. Dr. Bredesen, thank you so much for joining us tonight.
Yeah, okay. Thanks for the invitation here. Let me go ahead and share my screen here. Okay, there we go. There we go. Share that. Okay, can everyone see that okay? Hopefully. Okay, there we go. Okay. So, it is interesting to me, having trained as a neurologist and very kind of classically training, at Caltech and MIT and Duke and Harvard and all this. And then where we have nothing, classical medicine has nothing to offer Alzheimer's disease. And as you indicated earlier, the Alzheimer's Association is basically saying, that there's nothing to offer, but maybe we can, maybe we can have a symptomatic effect. So as I'll show you today, that is completely wrong. And in fact, we need to be looking at what actually moves the needle. And we've spent 30 years, we published over 220 papers in peer-reviewed journals. And the whole point of the laboratory research was to understand the fundamental nature of the neurodegenerative process well enough that we could actually begin to fashion the first effective treatments. Because as you know, this has been the area of greatest biomedical therapeutic failure. As they say, everyone knows a cancer survivor, no one knows an Alzheimer's survivor. And there's some interesting parallels with what's happened with COVID-19 as well. And we'll get into that. But the bottom line is, it continues to amaze me that people who have absolutely nothing to offer are complaining when there's something to offer. And so when people say this sort of stuff to me, I always say the same thing. Look, you line up the people that you've made better, I'll line up the people that we've made better, and let's take a look at the lines. We've had hundreds and hundreds and hundreds of people improve. And as you'll see from the trial, very exciting results with the trial. Okay, so this is essentially a pandemic without a vaccine. And so just for some perspective, and let me just minimize this here so I can see all the slides a little better. COVID-19 has killed, now we just passed 600,000 people in the United States. Alzheimer's will lead to the death in nearly 100 times that many of the, so if you look at all the currently living Americans, about 45 million will die. As Ben mentioned earlier, about 5.7 million are already recognized. But of course, younger people, we don't know that. We have two daughters who are 29 and 31. We don't know if they're going to get it or not. So if you take everyone who's currently living, statistically, about 45 million will die of Alzheimer's. So this is a huge, huge pandemic. And let's hear. Okay. So the problem is a fundamental one, and we don't hear enough about this. We're always told, well, it's something about the plaques and the tangles, and we're trying to figure that out, and maybe the next drug is going to work. And of course, there are over 400 failed trials for drugs. But the fundamental problem is not talked about enough. The fundamental problem is that, for example, COVID-19 is a simple disease. We know what causes it. We even have sequence from the virus. We have sequence from the mutants. All these things. We know what to do for prevention. We have the vaccines developed. Whether some people like them, some people don't. At least we understand the disease itself. That is not the case for Alzheimer's. It is a chronic, complex disease of unknown etiology. And people keep on, as I'll show you, they keep on thinking it's going to be one thing. Okay, we're going to figure out what it causes it, and boom, we'll be able to do something about it. That's not the way this disease works, and it's important for us to understand that. So no surprise, billions of dollars, over 400 failed clinical trials. So we really need to take a completely different look. So what I ask you to do today is forget what you know, forget what you've heard about Alzheimer's for just a few minutes. And we're going to look at this from the ground up and look at what actually this disease represents, which is what our research had been all about. And so we want to develop a model that is consistent with all the papers published. There are over 150,000 published papers about Alzheimer's. None of them has led to any successful treatment. So we want to reconsider this and look at what we can do. Can we develop a model that is predictive, that tells us what's going to work and tells us what's not going to work? That would be such a helpful model because, as you may have heard, you look at something like aducanumab, where there's been very little help trying to get rid of amyloid. So if you could simply have a model that would tell you what's going to work and what's not going to work, it would be exceedingly valuable. The day that donanemab, which is another antibody that removes amyloid, it just came out about 8 weeks ago. And what they showed was it doesn't make people better. It doesn't stabilize people, but it slows the decline in the trial. It slowed the decline by about 1/3. The day that came out, the stock in its company, Eli Lilly, went up by $20 billion in total company value. So to be able to say, we understand this disease, we know what's going to work, we know what's not going to work, and we know when to use it, would be a very, very important thing. So let's talk about that. And I think everybody here, anyone who's interested in functional medicine, and I have to say, I really appreciate Jeffrey Bland's contributions over the years to this whole idea. Everyone understands that there's a fundamental difference between simple illnesses and complex chronic illnesses. So here's simple illness, which we all dealt with in medical school. If you've got someone with pneumococcal pneumonia, yes, if they've got alcohol on board, they're at increased risk. If they have diabetes mellitus, they're at increased risk. If they have abnormal B cells, for example, people with multiple myeloma do poorly with pneumococcal pneumonia. And there are lots and lots of other contributors. But we as physicians have gotten away over the years because of the fact that the pneumococcus itself is so much more important than any of these other variables, we've gotten away with writing prescriptions for penicillin, amoxicillin, cephalosporins, what have you. And that's been good enough, even though it doesn't address all the contributors. That's great for a simple illness. However, here's the problem. In the 21st century, we are virtually all dying of complex chronic illnesses, Alzheimer's and cancer and cardiovascular disease and Lewy body and Parkinson's, all these sorts of things. So therefore, when you look at those, they are fundamentally different than these simple illnesses. So let's look at Alzheimer's for a minute. Insulin resistance is one critical risk factor. Various pathogens, everything from Borrelia to Bartonella and Babesia, to herpes simplex from the lip, to P. gingivalis from the oral microbiome. These are all things identified by the neuropathologists in the brains of Alzheimer's disease patients. So these are critical. NF-kappa B, which is simply activated in your cell when there is ongoing inflammation, turns out to be important, and I'll show you why. Mercury, inorganic and organic mercury, turns out to be important in your risk. Various mycotoxins turn out to be important. Various organic toxins, high homocysteine, poor methylation, and we could go on and on. There are dozens and dozens of contributors. The good news is it appears that there are not thousands. There are dozens and dozens, somewhere probably fewer than 100. But it's not one or two. And as you can see here, the big difference between pneumococcal pneumonia and Alzheimer's disease is that there's no one of these that outstrips the others the way the pneumococcus did for pneumococcal pneumonia. Therefore, we can't simply write a prescription that says, here's a prescription to treat your homocysteine. It's not that simple. Therefore, we need to flip the script. We need to look at all the different contributors in each person and then address those with a systems medicine or precision medicine sort of approach. Therefore, no surprise, you can go at trial after trial after trial that has failed. And as an example here in the middle, semaglutide, that was from Eli Lilly. They spent over $500 million developing semaglutide. Not only did it not help, it actually made the disease worse. Dimebon, here you can see they didn't believe it when it failed the first time. They did another trial, this time with Aricept. It failed again. So there's something fundamentally wrong about the way we're going about this when you're seeing such failure time after time after time. So here are theories of Alzheimer's, and there are others. These are many of them, but not all of them. And there are ones, and bottom line is none of them has led to an effective treatment for Alzheimer's. What the heck is wrong? We have to understand that. So the dominant theory over the last 25 years has been the amyloid cascade theory. And that came about basically for two reasons. There are people who have mutations in the amyloid precursor protein, and they develop familial Alzheimer's. That's rare. It's fewer than 1 in 1,000 has the APP mutation that is associated. There are several of the mutations that are associated with this. But it's about just over 100 families worldwide. So it's not a common cause. But the idea was, okay, this amyloid is bad stuff, and we're going to get rid of the amyloid and you're going to be all better. And then this has been tried time and time again with various pharmaceuticals, bapineuzumab, crenezumab, gantenerumab, aducanumab, it goes on and on and on. Nothing. They have not had success. Okay, tau. And other people just say, okay, well, amyloid is not important, but tau is important. Well, yes, they're both mediators of what I'll show you is happening. That is a mediator of a downsizing of the brain. That's actually a physiological response to various insults. And then, of course, prions. And actually, my mentor, Professor Stan Prusner, discovered prions and was awarded the Nobel Prize in 1997 for his discovery of prions. Again, these are mediators of the disease, but in general, people are not getting this because they're catching prions. We believe that this is actually part of the downstream signaling. Type 3 diabetes, we hear that term all the time, and there's no question most of people with Alzheimer's do have insulin resistance, but you don't have to have that to get Alzheimer's, and you don't have to have type 3, you don't have to have diabetes to get Alzheimer's, you don't have to have Alzheimer's to get diabetes. So the bottom line is it's neither necessary nor sufficient, but yes, it's an important overall player. Chronic herpes simplex, nice studies out of Taiwan showing that people who actually treated their recurrent herpes simplex oral, labial here, they actually had a reduced risk for Alzheimer's. Gingipane. So there's a whole company that is arranged around the idea that we've got these P. gingivalis, which are associated with poor oral health. They get into the brain and they're producing a protease called gingipane, and that's what's doing the damage. Likely that's part of it. Unlikely that that's the whole story. Mercury toxicity, again, treating mercury has turned out to be helpful for a number of people. Metal binding by amyloid, this goes on and on. Reactive oxygen species, APP amplification, that's some nice work out of UC San Diego. Cortical demyelination, vascular leak, it just goes on and on. None of these has led to a successful treatment for Alzheimer's, and that's really ultimately the acid test. So here's the problem. Sorry, Ben, what's that?
Yeah, can I just make a comment about the amyloid?
Sure.
I think the amyloid, nobody's asking why is there amyloid there in the first place, and you just mentioned the amyloid binding to the metal, and We've learned that amyloid is a way to protect the brain against infections and inflammation. And that's really the key, is asking the additional question, what's the root cause? Why is the amyloid there in the first place?
Yeah, absolutely. I think it's critical to understand that. And the amyloid hypothesis just says you have too much amyloid for some reason, and that's why you get Alzheimer's. And it really doesn't give you any insight. And we know now, if you remove that, you don't get better. And in fact, what we found, a number of people actually get worse when they remove the amyloid, because again, as you said, it is a protective response to these various insults. So here's the problem. If you go to an Alzheimer's center or an Alzheimer's center of, quote, excellence today, what they'll tell you is that there's a cause. We don't know what it is. There's some cause that's unknown. This is a disease called Alzheimer's. There's a treatment. It's a monotherapy, Aricept or Namenda. You can also use Exelon. It's the same idea. It's one phase. We're going to give you the same thing each time. We're going to stick with it, and it's going to be ineffective, and you're going to die. And it's just a horrible, horrible state of affairs. I have to say, it's pretty barbaric right now. The research findings, on the other hand, show us something completely different. What they say is there are dozens of contributors, as I mentioned earlier. We initially identified 36. There are a few more, low 40s, but it's not thousands. Therefore, no surprise, there are subtypes. You see people who have more of an inflammatory type of Alzheimer's, people who have more of an atrophic type, and we'll get into the subtypes in just a minute. And therefore, no surprise, there are many personalized programs, and you've got to keep optimizing for the person. And we have people who will improve, and then they'll plateau, and then we find another contributor, and then we address that. They improve still further. This happens all the time. So some of the causes, when you do see people with cognitive decline, and since I assume that most people here are seeing some people with cognitive decline, let's talk for a minute about what causes cognitive decline. As Ben said earlier, the most common Alzheimer's disease. And let me just take a moment, this idea about mild cognitive impairment, this is the third of 4 stages to end-stage Alzheimer's. So we really need to find new nomenclature for this idea of mild cognitive impairment. This is just like saying mildly metastatic cancer. Yeah, okay, well, it's already metastatic cancer. That's a very late stage of cancer. And it's the same thing with Alzheimer's. MCI is a late stage of the problem. You go about 10 years of SCI before you ever get to MCI. Now, Lewy body disease, about 1 million people in the country. Parkinson's, also about 1 million people in the United States. And actually, Parkinson's is the disease in neurological degenerative diseases that is on the greatest rise right now. It seems to be linked to various toxins. So these things are critical. Lewy body, of course, the classic is people with visual hallucinations. Otherwise, it looks a lot like Alzheimer's in many respects. They have a few other features. They tend to sleep late. They tend to have something that's called showtime, where they get really good and they get really bad. They're very sensitive to drugs. They can, if you give them classical antipsychotics, they can actually die. So you have to be very careful about those people. Keep an eye out for those. Vascular dementia, of course, very common as well. And especially if you have people who have sudden stroke-like changes, something to look at. An MRI can be very helpful at picking up that. Normal pressure hydrocephalus, it's been claimed that 1 out of 10 patients with dementia has normal pressure hydrocephalus. I myself think that's too high. I would argue more like 1 out of, a couple out of 100 maybe. Not common, but you will see it at some point. You don't want to miss it because it's very treatable with a shunt. And the classic, the thing to ask and the thing to look for, if these people don't have the triad of gait apraxia, urinary incontinence, and dementia, simply they must have some degree of urinary urgency. If they don't have urinary incontinence or urinary urgency, very unlikely. Again, if you get an MRI that shows that you've really got these blown up ventricles and no atrophy, it's something to think about. So you don't want to miss that one. Frontotemporal dementia, interestingly, is a cousin of ALS. These things often run together. They both involve a protein called TDP43. It's a tough one. It's only about 1/20th as common as Alzheimer's. So not terribly common, but again, something to keep an eye out for. And then there's a new one that was just described about a year ago called late limbic predominant age-related TDP-43 encephalopathy. That's a mouthful, but it is like frontotemporal dementia, but it's in people who are over 80. So this is the one, it affects the limbic system and it affects the temporal lobes. So different place than frontotemporal dementia, but same pathology with the TDP-43, which is present in ALS and frontotemporal dementia and late. So if you see someone who has slowly progressive Alzheimer's that didn't start until they were over 80, good chance that that's late, especially if they have a negative amyloid scan. Then, of course, multiple sclerosis. Interestingly, people with multiple sclerosis have actually cortical shrinkage of about a few percent per year. So they actually do, over time, often develop some degree of cognitive decline. And that's why things like Terry Wall's protocol, I think is fantastic, really addresses the key points for MS. And then PSP, progressive supranuclear palsy, another thing that can present with cognitive decline. These people, the classic, have them look up, have them look down. These people have trouble with vertical gaze. And then corticobasal degeneration. This is another Parkinsonian-like presentation. These people often have something called alien hand. So these are less common things, but something to keep your eye out for. And then CTE and TBI. So trauma, huge player. NFL players, people who've been in the war, blasts, traffic accidents, even repetitive mild head injuries, people who head soccer balls, all these sorts of things can give you chronic traumatic encephalopathy. The triad to think about for that, so if you hear this triad, so it's depression, aggression, and dementia. So what happens to the football players? They beat up their families and then they commit suicide. They have both aggression and depression as well as the dementia. COVID-19 related, this is something for all of us to keep our eyes out for. A lot of people with COVID report some brain fog even after the COVID. And so there's concern on many corners. Are we going to see more and more cognitive decline as a post-COVID effect? We just don't know yet. Of course, everyone's concerned thinking back to post-encephalitic Parkinson's of 100 years ago. And we'll see what happens with COVID-19. But it certainly, again, behooves everyone to get on appropriate prevention.
Hey, Doc,
and then,
just a second. What would you speculate would be the mechanism if we start seeing brain-related issues related to COVID? Do you think it might be related to decreased oxygen getting to the brain? Do you think there's an autoimmune attack on the brain? What do you think might be the mechanism?
Yeah, so there have been multiple neuropathological studies already published on COVID-19 related encephalopathy, and it actually has several features. So just what you said. One is you do see multiple small vessel occlusions. So there is some degree. It's not major vessels typically. Now, sometimes it is major vessels, but more commonly it's small vessels. There was an interesting publication from, what's that?
This is the clotting and the vascular component of COVID.
This is one of the contributors. Then the second thing is there is an autoimmune effect. So there's a little bit of an MS-like phenomenon. So you've got people reacting to virus and virus antigens. And then you've also got previous damage where you had from hypoxemia, depending on how severely, were they on a respirator? Were they not on respirator? Those sorts of things. So there are multiple mechanisms. And I do think this is something where everyone who's had COVID-19 should be on active prevention. And certainly if they develop more than just brain fog, especially, then you really want to jump on them early and evaluate them and do everything possible to optimize it, give them the appropriate immune status. Interestingly, there are some very interesting parallels, as I mentioned earlier, between Alzheimer's and COVID-19. And one of the more interesting ones is that one of the problems with the disease is that both in COVID and in Alzheimer's, you have a mismatch between the innate immune system, which is activated, and the adaptive system, which is not able to clear the pathogens. In one case, we know what the pathogen is. In the other case, it can be all sorts of different pathogens with Alzheimer's. But it's been known for years that Alzheimer's people aren't particularly good at phagocytosis. They're not particularly good at antigen presentation. So part of the job of the adaptive system is to turn down the innate system and say, okay, I'm going to take it from here. But it doesn't succeed in doing that. So what happens, as we know, people with COVID-19 have cytokine storm and can die from that. With people with Alzheimer's have cytokine drizzle. It's not an active cytokine storm. It's years and years of this. And by the way, the amyloid we associate with Alzheimer's is part of the innate immune system. That's the whole point. So as long as your innate immune system is chronically activated, you're going to continue to make that amyloid. You are protecting yourself against an insult. So it's our job to find out what these insults are and go after them and target them. And then CJD, Creutzfeldt-Jakob disease, which is a prion disease, typically that is much more rapid. So you see people getting worse week to week instead of months to months and year to year. And then, of course, don't miss the subdural hematoma. Of course, your MRI should help you with that. But these people tend to wax and wane, and they can present with something that can look like Alzheimer's disease. So what about stages, subtypes, and presentations? 4 stages. So there's a pre-symptomatic stage. You already have the pathophysiology going on, and that can last for several years. But at the time, you don't notice any symptoms. Then you progress to SCI, which on average lasts 10 years. So again, I would argue that we should start calling this just like pre-diabetes. This is pre-Alzheimer's, and SCI is early Alzheimer's, because everything has been focused on the end stage of this, which really makes no sense. So SCI is subjective cognitive impairment. By definition, that means there's something wrong, but the tests are not showing it yet. That progresses to MCI, so-called mild cognitive impairment, but as one of the patients said, it's anything but mild. This means that you've progressed far enough that your neuropsych testing is now abnormal. And so you are relatively late in the process, and you really want to jump in and get treated optimally. And then that progresses at the rate of about 10% per year of the MCI patients will progress to full-on Alzheimer's, which is really end-stage Alzheimer's, which is, by definition, when you begin to lose activities of daily living. Well, as you know, when you're losing activities of daily living, you are very, very late in this process. So we recommend everyone, please, either get on active prevention when you turn 45, or think about the very earliest when you have symptoms, please get on treatment. So as I mentioned earlier, there are subtypes. Type 1 is inflammatory. Type 2 is atrophic. Type 1.5 is glycotoxic or sweet. Type 3 is toxic. And as I'll show you, it often presents very differently. Vascular, type 4, and then traumatic, type 5. And so depending on what type you have or what combination of types you have, you need to treat them differently. No surprise. The biggest thing to note is someone presenting with an amnestic syndrome, where the biggest problem and the first problem is really about learning new information. That's classical Alzheimer's, and that's typically not type 3. Type 3 is often a little different, but that's classical Alzheimer's. It's more ApoE4 positive Alzheimer's, which represents about 2/3 of Alzheimer's. But about 1/3 of people will come in with non-amnestic presentations. So they have problems with executive function. So here, non-amnestic. So for example, the primary progressive aphasia, that's a relatively common one. PCA, which is posterior cortical atrophy. So these are the people that have trouble with recognition of faces, recognition of objects, things like that. Prosopagnosia, problems recognizing faces, executive dysfunction, dyscalculia, apraxias, agnosias, depression. So these are all things typically that are parietal. If you look at a PET scan, you see a temporal and parietal reduction in glucose utilization. Classical Alzheimer's is more of a temporal heavy. It's memory. The non-classical, the non-amnestic, is really more of a parietal presentation. Those are the PCAs and the apraxias and the dyscalculias and things like that. And beware the ones that present with depression, because they are often telling you, I've got exposure to toxins. And that's a common presentation of the ones that are going to turn out to have type 3. So let's now go back to the molecular biology. We're going to go all the way back to the beginning and look at what this thing actually is. And that's our research over the years was, could we understand the fundamental nature of this disease? How do we explain the neurofibrillary tangles and the senile plaques and the atrophy and all this sort of stuff and the genetics and all the other things in these 150,000 papers? And the intriguing thing here is the amyloid precursor protein, which sticks out of a cell. So this is a cell membrane I'm showing you here in this diagram. Here's the extracellular space. Here's the intracellular space. And amyloid precursor protein turns out to be a fascinating protein. It is a little bit like the president of your country. So let's say that you're living in my Bredesen and you've got a president, President APP, and the president is looking at, are things good? Are we going to build roads and build bridges and do all these sorts of things? Obviously, things that our current president and our last president were thinking about. What do we do? There's a pandemic on the one hand, but we got to keep things going. Are we going to go into a recession? That's the same sort of thing. And by the way, this, again, there's a good analogy. What happened with COVID-19? We were all told there is SARS-CoV-2, there's an insult. So we're going to shelter in place, we're going to downsize. And of course, we had a recession. That's exactly what your brain is doing with Alzheimer's. It's saying there are insults around. I'm going to switch from growth mode to protection mode. So interestingly, APP senses both of those. And you can literally trace the molecular pathways. So when things are good, whether it's in your country or your brain, if it's in your brain, APP senses things are good. And again, as an example, estradiol binds to its receptor, enters the nucleus, turns on a whole bunch of genes. And one of the genes that turns on is the one that cuts right here. So it's saying, okay, we're going to cleave APP at one site. It leads to two peptides that are growth and maintenance. These are saying, go ahead, times are good, make new memories, grow, keep your brain doing well. Now, this same thing, when it's exposed to all the things we talked about, to herpes simplex and to pathogens from your mouth, to Borrelia, to leaky gut, to staying up too late, to too much stress. I mean, you can go on and on and on. When it recognizes those things, it has a completely different outcome. So it's now, just like your president, saying, we're going to protect ourselves and we're going to downsize. And again, you can trace a direct molecular pathway. So you then cleave APP at three sites. This is the beta site right here, the gamma site, and the caspase site. And these four peptides all say, pull back, protect yourself, and pull back. And so that's the fundamental difference. Everybody with Alzheimer's has got too much on this side and too little on this side. So it's our job to figure out what's driving that and to increase the things on this side and decrease the things on that side. And that's what actually works to make people better. Okay, so what we realized over the years of research is that chronic illnesses are typically signaling imbalances. As everyone knows, if you've got osteoporosis, your osteoblastic activity is being outstripped by your osteoclastic activity. If you have cancer, your somatic mutations typically are giving you more cytoblastic effect because you've got oncogene activation and you've got tumor suppressor gene mutation. You've lost that function. Therefore, cytoblastic outstrips cytoclastic, and you make too many cells. What we found in the lab, Alzheimer's no different. There are all sorts of things that contribute to synaptoblastic signaling, and that is being outstripped by synaptoclastic signaling from exactly what I just showed you with APP. That's recognizing this. So the point here is that the fundamental nature of this disease that we call Alzheimer's is actually a network insufficiency. So you have subsystems of your brain. You have a subsystem that is there for stabilization of motor movements. When that goes awry, you get Parkinson's. You have a subsystem that is very good with neuroplasticity. When that goes awry, you get Alzheimer's. And so each of these has its own supply requirements and its own demand requirements. In all of these diseases, you're outstripping. The supply is not meeting the demand. In the case of Alzheimer's, there is a set of things, as I mentioned, synaptoclastic. So let's just quickly go through this. Your probability of Alzheimer's is proportional to, over time, you're integrating a whole sum of things that are, and I'm going to talk about what they are here, synaptoclastic signaling over synaptoblastic signaling. So that tells you a lot about what Alzheimer's actually is. That's why your brain shrinks when you get Alzheimer's disease. That's why it acts like it's trying to protect itself. Now, the good news is, although we can't send a lab test for this one, I don't think that there's any sort of test we can do. I know Dr. Vojdani may be at work on something like this. He's made some great tests, but the reality is we can measure these things. So this is approximately equal to 4 different things. So the things that are on the bad side here, and then here are the things that lower the risk, but when you have too little of them, you're in trouble. So anything that's causing inflammation is going to increase your risk for Alzheimer's. So whether it's leaky gut, whether it's poor oral, whether it's poor dentition, whether it's chronic sinusitis, whether it's metabolic syndrome, just go on and on. Any toxins, and these come in 3 general types: the inorganics, things like mercury, and air pollution. Air pollution is a huge one. And then things like organics, things like formaldehyde and toluene, benzene, glyphosate. And then, of course, the biotoxins, things like trichothecenes and ochratoxin A and things like that. Now, too little energetics, that's the third of the 4 things. And the energetics are basically 4 major contributors: blood flow, oxygenation, mitochondrial function, and the actual ketones that are actually going to be burned as a substrate. So that's one thing we want to optimize as well. So anything that reduces that, people who have sleep apnea, people who have some degree of vascular disease, people who have poor mitochondrial function, people who are incapable of getting into ketosis, all those things. And then finally, trophic support. And that's, again, 3 things. That is growth factors, NGF, BDNF, things like that, hormones, estradiol, testosterone, pregnenolone, progesterone, all that stuff. And then nutrients, things like vitamin D. So those are the big 4. And so each one has groups, and you can literally go through and figure out what each person has that's giving them this problem. And what that means is the perfect Alzheimer's drug, and we spent years screening for Alzheimer's drugs, the perfect drug would have to do this, which makes it really, really difficult to get a single drug. And I do think the drugs are going to be very helpful in the long run as part on the backbone, basically, of a functional medicine or systems medicine sort of approach. So we always tell the patients, imagine you have a roof with 36 holes. You got to patch many of them before you're going to see any real effect. And of course, we have to train a new kind of physician who understands both systems biology, the traditional Chinese medicine sort of approach, as well as DNA, RNA, larger data sets, all of the modern things. And so we really need to get, and this group is very well aware of that. So I'm just going to spend a couple of minutes here on ApoE4 because it is the most common genetic risk factor. What the heck? Why would this give you Alzheimer's? It's so incredibly common. Even though about a quarter of the population has it, it represents, because of this increased risk, about 2/3 of all Alzheimer's patients. So if you have 0 copies of ApoE4, and that's 3/4 of our population, you have about a 9% risk. It's not 0, but it is relatively low. If you have 1 copy, that's 75 million Americans. The vast majority don't know it. They have a chance about 30% during their lifetime. And if you have 2 copies, your chance during your lifetime is well over 50%. That's 7 million Americans. Most likely you will develop it. So we recommend, please, everybody, check out where you stand. People used to say, don't. In fact, by the way, the standard claim today from the experts, don't bother to check it because there's nothing you can do, which is just, it just drives me crazy. There's a tremendous amount you can do. Please, everybody, find out where you stand. Get on active prevention.
So, Doc, an opinion about ApoE2 versus ApoE3?
Yeah. And yeah, so ApoE2 is actually reduces risk. It's relatively uncommon. ApoE3 is the most common. And that one, the risk is going to, that's the one that's set as the standard. And so, yes, if you're a 2-3, you do have a slightly lower risk than 9%. However, if you're a 2-3, be careful. You are also susceptible to some of the toxins more than the ApoE4 people are. So the ApoE4 tend to get a more vascular and inflammatory and glycotoxic type of disease. The ApoE3s and 2s tend to get a more, in general, they tend to get a more toxic, sometimes vascular as well, but they tend to be more on the toxic side. So what had been known is that ApoE4, some sort of risk factor, not clear how that works. ApoE is a little bit like your butcher. It's the guy that carries around the fats. And so what the heck does that have to do with Alzheimer's? And so we started in the lab over a decade ago looking at how do you turn ApoE4 into Alzheimer's disease? Well, why is this association? And it had been claimed in the past it's simply because you clear your amyloid less well. And yeah, you do clear less well, but that's not the only reason by far, as you'll see here. It turns out to be a fascinating story. So what happens is this ApoE4 was the primordial ApoE. So when the hominids appeared from the simians between 5 and 7 million years ago, there actually aren't that many differences, as you probably know, between the simians and the hominids. The DNA is over 95% similar. And so as I told my wife, my DNA is actually more similar to a male chimp than it is to yours. And she said, well, duh. Of course, you guys both like ESPN. You both like the Three Stooges. We get it. Okay. So the bottom line is, yes, there are a lot of similarities between the simians and the hominids. And of course, God touched us all with DNA, made a small number of changes, and lo and behold, we became what we are today. And we all had, for 96% of human evolution, everybody was ApoE4. And so these are interesting. The ApoE3 just appeared 220,000 years ago, so relatively late in hominid evolution. Nobody knows why it appeared then. One of the interesting possibilities is that ApoE4 is a very pro-inflammatory gene. So it's great for if you're eating raw meat and things like that. And that as people became able to be eating cooked meat and things like that with fire, they didn't need that. And so they ended up with ApoE3, which is now the more common one. So you can see here what happened. ApoE4 looks like columns on a house. And that's because this arginine 61, which is positively charged, interacts with glutamate 255, which is negatively charged. And interestingly, this arginine 61 is not present in the chimp ApoE. Now, what happens is 220,000 years ago, cysteine 112 appeared right here and swiped right on the ARG61. And you can see here, these two guys interact now. So this now swings free. And so now it looks much more like a nutcracker than it does like these columns. So very different look. And as I mentioned, this is just a relatively late change. Here's the ApoE3 just appeared late in our evolution, ApoE2 just 80,000 years ago. And here's the big surprise. People had known that it binds to receptors, several different receptors actually. But what we discovered was really fascinating. It actually interacts with part of NF-kappa B, REL-A, and enters the nucleus. And the reason that hadn't been picked up before is it's not all of it that enters the nucleus. It's a subpart. It's about 10%, but it's a critical part of your ApoE that enters the nucleus, and it binds to 1,700 different gene promoters. And if you group these, you could not tell a better story for Alzheimer's disease. So it's involved with inflammation. It's involved with disassembling your microtubules. So it has this interesting pro-inflammatory effect. And so, okay, we can find out who has it. We can actually make an impact on this. So treatment. And so the bottom line here is when we treat people, we want to understand what's causing the problem. We want to know what their energetic status is. We want to identify whether they have insulin resistance and get them to be sensitive again. We want to know the status of their trophic support. We want to resolve inflammation, treat pathogens. If they've got toxins on board, we want to detoxify them. We found that people do better if they have some mild stimulation, whether it's light, whether you like to use magnetic, defocused laser, any of these things. We want to improve the adaptive immune system and reduce the innate system. That's one of their problems. And then we can remove the amyloid. Removing the amyloid at the beginning is a bad idea because it's protecting you. So address the things. It's root cause medicine, no surprise. And then ultimately, we want to think about regeneration, things like stem cells and trophic factors. So here's an example of a guy who did very, very well. You can see these dramatic improvements in his neuropsych testing. He actually started back in December of 2013, so he's done very well for a long time. And that's the most important thing. People have stayed very good. This is a guy, classical Alzheimer's, ApoE4 positive, both parents died. And you can see, as a functional medicine physician, you can see the problems this guy has. Now, he himself is a very smart doctor. And I was trying to explain to him, look, this is why you have Alzheimer's. And he said, well, addressing these things, none of these things is a cure for Alzheimer's. No, not by themselves. But you have to look at the overall system. And by the way, he did absolutely great, responded metabolically, cognitively, volumetrically. And his neurologist said he's now normal. You can see his hippocampal volume, just dramatic improvements. And you can also see he's not perfect with his metabolism. His fasting insulin is much better. It's not perfect. His HSCRP, much better. It's not perfect. His homocysteine, pretty good. His vitamin D, pretty good. So he was, improved. And you can see here, his gray matter actually increased by 23%. What's that?
I'm sorry, what would be your goals for fasting insulin and those other parameters?
Yeah, fasting insulin, we usually go with what Mark Hyman has always suggested. We want to be in the kind of 4 to 5 range. I worry when I see people down at 1, unless they're doing really, really well. Often this is, if they're at 1 and their hemoglobin A1C is at 6, they're just not able to make enough insulin. And by the way, they often get better as they start being treated and they're now able to make more again. But yeah, 4 or 5. I like to see their HOMA-IR right around 1.0. And his HOMA-IR was something like 13 or something. It was just way, way off scale. So we published a number of papers on this. And of course, everybody pushed back and said, yeah, these are anecdotal. You got to do a trial. So we actually tried to do a trial back in 2011. It was turned down because it was multivariable. We got turned down again in 2018. We finally got approved in 2019. And we just finished the trial, and I'll show you the results from that. Published a couple of books about this to document some of these. And so, as you know, functional medicine has improved outcomes for many illnesses. It's really been striking. And of course, this is not taught in medical schools typically. One leader of one of the medical schools, a very well-known medical school in the United States, said, we'd like to teach this new kind of medicine, but we can't do that until all physicians accept it. Well, of course, all physicians won't accept it until you teach it. So it's a really very, very backwards approach. So clearly, if we're all going to make functional medicine the standard of care, it's going to be important to perform clinical trials to prove efficacy. So therefore, we proposed a proof of concept trial, which, as I mentioned, just finished up, and we just published the first piece on one of these preprint servers called medRxiv. And I'm really honored to have done this with Dr. Ann Hathaway, Dr. Kat Toups, and Dr. Deborah Gordon. I'm sure a number of you know them. They're absolutely fantastic physicians. And we all worked on this together, along with the Four Winds Foundation that funded the trial, QuestGen, which is a CRO, Dr. Cyrus Raji, who was the neuroradiologist, and Alan Boyd, who is the neuropsychology guy that provided the CNS vital signs. So it's the first trial in which we flip the script and say, okay, let's find out what causes. I mentioned it was denied a few times. It's a small proof of concept trial, 25 patients with MCI or early dementia, MoCA scores of 19 or above, compares a personalized precision medicine approach and to historical outcomes. And so we're following this up with a larger randomized controlled clinical trial. So we look at MoCA, 0, 3, 6, and 9 months. We look at CNS vital signs because it's more sensitive. We look at AQ21, which is from the patient's partner, looking at how many complaints they have. We look at AQ20, which is basically the partner saying, did they improve, did they not improve, in 20 different areas. A little improvement, a lot of improvement, none, or were they actually worse? And then we did MRI with volumetrics at 0 and 9 months. and really striking results. So we tried to achieve insulin sensitivity, mild ketosis, healing the gut, treatment of identified pathogens, detox for those who needed it, reduction of inflammation, optimization of hormones, nutrients, and trophic factors, vascular status, some degree of brain stimulation, optimization of SpO2, and then stress management and improved heart rate variability. And I just want to say a word about the semantics of success. We hear this almost every day. Oh, someone did a trial, someone made a mouse better, or someone, slowed up the decline. So here's an example, donanemab, which is the big success in the antibodies, the drugs. What it did was it didn't make people better. It didn't stop the decline. It slowed the decline by about 1/3, a little less than 1/3 actually. And so you can see here, here's no treatment. Yes, you go downhill with this big success. And this thing, by the way, the day this was announced, the value of this company increased by $20 billion in one day. So here you can see it slowed it by 1/3. Whereas in our trial, we didn't just slow the decline, we made people better. And here's an example on the neurocognitive index. You can see where they were at baseline. What's that?
What was the change in the market value of Dr. Dale Bredesen as a result of the trial?
I think 3 more arrows in my back. That's what happened. That was the result of that one. So yeah, there's no market value here. So here's just from the NCI data and the significance of this P less than 0.001. So everything I'm showing you here turned out to be significant statistically. So here you can see MoCA 0.001, 76% of the patients improved. Neurocognitive index, less than 0.001, 84% of the patients improved by their NCI. Cognitive subtests, verbal memory improved, executive function, psychomotor speed, cognitive flexibility, and others. Interestingly, the partners said the same thing. Yes, they said these people have improved. Again, p-value for that 0.005. Brain training scores improved in all 25 of them. No question the pandemic affected this. We had 7 people who had already improved by 6 months. The pandemic hit, and then they actually went down a little bit at the end. But the good news is the other ones improved so much that it was still statistically significant as a group. But there's no question they would have done better as a group if the pandemic hadn't intervened. Now, here's what's interesting. The MRIs improved. So if you look at the overall MRIs, they improved both with respect to gray matter volume and with respect to hippocampal volume. There we go. Hippocampal volume itself. So hippocampal volume in someone with Alzheimer's goes down about 2.5 to 3.5% per year. If you're a normal individual, it still goes down about 1.7% per year. These people, the hippocampal volume actually did go down a little, 1.29% per year. So these people actually did better than the normal controls with their hippocampal volume change. And interestingly, their gray matter volume actually went up by 0.3%. So implications, cognitive decline is reversible for most people with MCI or early dementia. Now, we're very interested in looking at later dementia. What about people who have MoCA scores of 0 to 18? We've seen anecdotal evidence of improving them, but it may take more to get them to improve. We'll see. For those with cognitive decline, likely contributors should be obvious. So one of the interesting things that came out of this was the people, there were only 3 who didn't improve, who declined. We should be able to tell why. And we could see one of them, for example, lived in a very moldy house with lots of mycotoxins and just said, I'm not leaving. Okay, this person continued to decline. So the good news is we could tell with these people what was actually wrong. And the other ones that did the right things actually improved. So one of the issues here is how feasible is this to do with everyone? So we need to continue to work on the practical nature on this. The good news is the results really strongly support doing a larger trial, which is what we're setting up now. I'm excited about the idea that we may be able to modify this for Lewy body, modify it for Parkinson's, modify it for frontotemporal. Each one has its own subsystem with its own neurochemistry. So we should be able to modify this. And we're already doing this. In fact, I just had a meeting today on the 3-month follow-up of the first couple of patients with macular degeneration. And it's the same story. They have their own separate neurochemistry, and we can now begin to look at improving them by combining the appropriate things. So the good news is, if you combine the results of this trial with what's already been known, that there's a decades-long pre-symptomatic and early symptomatic period, the fact of the matter is Alzheimer's is now, it is now something that is optional. It's not that anybody has to get it. So please get on prevention or early reversal. You don't need to get this disease. Just as for leprosy and polio, which were scourges in their time, Alzheimer's disease shall become a former scourge. And one of my favorite sayings is actually from a rabbi who said, "You're not expected to complete your life's work during your lifetime, neither are you excused from it." And I recognize this is going to be going on. I'm just about to turn 70. This is going to be going on long after I'm gone. But my hope is that we'll keep making this better and better, and we really will. We really will reduce the global burden of dementia. So let me stop the sharing there, and happy to go to any questions that anyone would like to ask. And thanks again to Ben for the invitation.
So the first question I'd like to ask is, I found a paper that you wrote about rapamycin and its potential for inhibiting mTOR and playing a role in prevention and treatment of Alzheimer's. Can you talk about that?
Yeah. So here's the thing about mTOR is one of these several, as you know, sensors. So these are all about nutrition and energy. And when you are eating, when you've got a lot of protein around, especially, mTOR is active, and so you want to inhibit this, and that's what you're doing by fasting. Rapamycin has been touted by some as here's the way of the future. Let's all take rapamycin and inhibit mTOR, and we'll age less rapidly. And I should mention, there's a great paper that just came out recently from Kara Fitzgerald, another integrative physician, who used a similar sort of approach to what we do, but instead of asking the question, what happened to cognition, said, what happened to aging parameters based on the methylome? And what she showed, that these people aged backwards by essentially by 3.26 years. So I think we're all trying to have that impact to improve brain function, to improve biological aging. I don't think you need to take a drug like rapamycin that has side effects to get that. You're getting it by doing things like fasting appropriately. Look, if you want to try the fasting mimicking diet, that's what it's for. Doing exercise, getting appropriate sleep, minimizing your stress, having a mildly ketogenic, plant-rich, high-fiber diet with plenty of phytonutrients. These are all ways to get at mTOR without taking a toxic drug.
Kara mentioned in her article about this test to measure biological aging based on methylation. I'm sure you're familiar with that. Is there a correlation between the outcome of that test and the risk of Alzheimer's?
Great question. We don't know yet. We're actually going to be working with Kara. I've just been talking to her the last few days. We're going to be working with her on this next trial to see what happens, because I think it's highly likely that we will see reduced biological age, given everything that we've seen so far with cognition and what she measured in her trial. So I'll be very interested to see what happens with that. But again, this is a biomarker of biological aging. We don't yet know if it's going, if we impact it and we reverse it, are there going to be, presumably there are going to be some good things that happen, but are there also going to be some negative? We don't know yet.
What about strategies to increase oxygen to the brain, like hyperbaric oxygen, ozone? There's several others.
Yeah, there's a group in Israel that is claiming that they're getting some very good results with hyperbaric. I think for the appropriate people, it seems to be very helpful for people who have vascular disease as one of their key contributors, or for people who have head trauma as one of their contributors. Whether it's the best thing for the people who have glycotoxicity or just inflammation, I don't know yet. I actually like EWOT a little bit better, the exercise with oxygen therapy, because you're now active as opposed to HBOT where you're inactive. But yes, I think for appropriate people, and especially in those two groups I mentioned, I think it's fine. As you know, it's also, it's expensive. And so, we're looking at how do we get this to the greatest number of people. And by the way, aducanumab, which failed, was turned down by the FDA, but now has been pushed by Biogen for the FDA to reconsider it. And they're going to issue a response by June 7th. Even though it failed in trials, one dose in one trial, it seems like it might have slowed a little. Again, didn't make people better, just slowing the decline. It will cost people a minimum of $30,000 per year. So again, we can do far, far better. And by the way, the average person with Alzheimer's will spend $350,000 before death, mostly to things like nursing homes and medical care and things like this. So for a tiny fraction of that, we can do much, much better.
Several questions came in about some of the particulars of the nutrition program and the parameters related to the type of intermittent fasting that you're recommending.
Yeah, great point. And so we use, and I wrote about it in the books, Keto Flex 12-3. So again, we're agnostic about what to use. It's how do we drive your biochemistry and neurochemistry toward the best places for synaptogenesis and for synaptic maintenance. That's the key. And so far, the diet that seems to be working best is it's a plant-rich, no surprise. And again, for people who have truly severe vascular disease, maybe you consider going vegan. For people who don't have a significant amount of vascular disease, you want to do more fish and some pastured chicken maybe, and maybe some grass-fed beef, but not as major parts. So it's a plant-rich, high phytonutrient, lots of non-starchy vegetables, high fiber diet. You want to optimize microbiome, no surprise, and have appropriate prebiotics. Make sure you don't have dysbiosis. That's one of the most common contributors to systemic inflammation and Alzheimer's disease. And then, as you indicated, some fasting, 12 to 16 hours we recommend. And then it's key. I see this again and again and again. If you can become insulin sensitive and get yourself into mild ketosis, you do better than if you are insulin resistant and you don't get yourself into ketosis. So that is an important part of the overall approach.
I know vascular issues is one of the categories, and that could affect decreased blood flow, et cetera, blockages.
Yeah.
On the other hand, is there a danger with some of the medications like statin drugs, and is there a danger lowering the cholesterol too much given the importance of cholesterol for neuronal formation?
Yeah, absolutely. And I worry about this all the time. And the problem is that in studies, the studies were done to try to show that the statins are going to save us from Alzheimer's. And of course, no surprise, they showed the opposite. However, they didn't show much in either direction. And I believe that is because they do have an effect on a reduction of some degree of reduction of inflammation. Well, we can do much better. We don't need statins to reduce inflammation. So again, we want to use what is most natural, what is most physiological. You can reduce inflammation. Let's find out why you have inflammation and let's remove that. Is it leaky gut? Is it oral dentition? Is it dentition, oral microbiome? Whatever it is, let's fix that. And then you won't need those sorts of things. Lowering your cholesterol is horrible, and everyone wants to lower their cholesterol to zero, and it's just crazy. We'd like to, if you're concerned about that, please check your LDL particle number or your SD-LDL or your oxidized LDL, whatever you like. We also like to look just simply at TG to HDL ratio, your triglyceride to HDL ratio, another good marker. Not total cholesterol. And I really dislike the use of statins because they have negative impact. You can get the positives. And by the way, many of the people who've gone on this and the three physicians who were seeing the patients noticed the same thing. People came off their antihypertensives, they came off their anti-diabetic drugs, and they came off their statins because they no longer needed these things.
So all the neurologists who were pissed off at you, now you got the cardiologist upset too.
Yeah. Well, yeah, so it's interesting. We were just talking about a patient earlier today, and that very thing came up. This person had significant vascular disease. And I said, okay, well, are they seeing a cardiologist? Yes, they're seeing a cardiologist. Okay, what did the cardiologist do? The answer was statins and hydrochlorothiazide. I mean, nothing about diet, nothing about exercise, nothing about stress, nothing about sleep. This person could have had sleep apnea for all the cardiologist knew. I'll tell you, it gets to the point where it is criminal negligence. It's unbelievable. So my argument is we need to now form new departments in each medical school called the Department of Modern Neurology. That's really what we need to do, because there are so many departments that are just stuck in the 20th century.
Well, we mentioned earlier before we started that it takes approximately 17 years for a new idea to get incorporated into medical practice.
Yeah, absolutely.
What do you think about some of the ways to increase using red or infrared laser to stimulate the brain?
Yeah, absolutely. So there's a lot of research going on, as you know, on this. And what comes up again and again is frequency around 40 hertz stimulation seems to be helpful. Now, unfortunately, some of this stuff, what they're trying to do is see if they can simply remove amyloid. And once you understand what the disease is all about, it's not about removing amyloid. It's about removing what's causing the amyloid, then getting rid of the amyloid. But it is true. Even interestingly, 40 hertz sound seems to be helpful, and 40 hertz light. And so that's the birth of via-light, for example. There's also magnetic stimulation that seems to be helpful, things like MERT. And Dr. Geraldine Brosfield over in Palm Springs has done some really nice work with that, as others have. And then, of course, Dr. Robert Hidayah has done some really nice work with laser. So, yes, there does seem to be an advantage when you're now, again, you're doing all these appropriate things. You're now saying to the brain, okay, we've now fixed all the issues that were stopping you. Now let's start kind of pushing you back into work again. Let's get your brain-derived neurotrophic factor firing again. Let's get your neurons firing again. Again, you don't want to do it at the beginning because you got to get things fixed. But once you do that, it's no different than, an athlete who's been out for 6 months with a broken leg. After it's fixed, so get them start up slowly, get them back on the track again, that sort of thing. So yeah, that's this is the sort of thing that is again and again proving to be helpful, or get him or her back on the track again. So this is again, the way our brains work. Is it any surprise that it's not just one molecule? Really? Are we really surprised by that?
Is it an appropriate analogy to compare amyloid with cholesterol? The reason why cholesterol, just like it's often not asked, why is cholesterol there? Let's just find some way to reduce it. When we really look at it from a root cause standpoint, we realize that cholesterol is there to coat the artery wall to prevent damage from inflammation, from oxidation. The body doesn't just do harmful things for no reason. And so is it an appropriate analogy that the amyloid is being laid down in the brain to protect the brain, much the way cholesterol is being laid down in the artery to protect the artery?
I think that the work that came out several years ago from Dr. Robert Moyer, the late Dr. Robert Moyer, and Dr. Rudy Tanzi, that showed that the amyloid is an antimicrobial peptide. I think that's really interesting and really important and fits perfectly with what we've been saying here. You are responding to these various insults, the insults of modern life. And so as long as you've got those insults there, you're going to be making this stuff. And so we want to remove the insults before we remove the response to it.
Somebody asked about using Prolon for fasting mimicking as a version of intermittent fasting.
Yeah, and I think it's fine. Some people prefer to go on a more kind of standard ketogenic diet, which is fine. Some people like to start out with a few days, several days of Prolon. Be careful. Some people just hate the taste of that stuff. They just don't find it very palatable. Others are fine with it. So yeah, absolutely. It's a reasonable thing to do. Now, be careful. What we find is that people who are very thin, have a very low BMI, they sometimes do poorly when you try to get them on a fasting mimicking diet. In fact, Walter himself, Walter Longo says, be careful if you're elderly or if you're frail or if you're too thin, be careful about this. So what you want to do then is cycle people, give them a rest day, and then cycle them in and out of ketosis about once a week. And then the rest of the time, keep them on ketosis, because we do have people who will actually do more poorly with their cognition when they start trying to do this kind of a ketogenic diet, because you have to remember, this is an insufficiency. This is a disease fundamentally of an insufficiency of a plasticity network. So therefore, if you've got someone who's very thin and can't generate the ketones and doesn't have much glucose around, et cetera, you're now really hurting them. So you got to be careful. So that's the paradox. It's a disease of insufficiency, and yet we got it often by excess. And so we've got to now bring these together, and we've got to have that fasting period without getting people to get farther into an insufficiency.
Do you ever include acupuncture in your protocols?
It's a great point. We didn't use it in the trial, but absolutely, for appropriate things, we used, other approaches for things like stress reduction and things like that. But yeah, it's certainly reasonable. And there are many things. As a scientist and a scientific physician, I never believe, I thought all this stuff was crazy 15 years ago, but I can't argue with the data. There's no question. You have things like TM, which actually clearly help neuroplasticity, clearly help blood pressure, clearly help stress. We had a patient just a couple of weeks ago, was talking to the husband of one of the patients, and she had a lot of tremendous mycotoxicity. She's slowly getting better, and then she's starting to go downhill again. I'm like, what the heck? We're looking at all the different parameters. And it turned out the biggest issue with her, she was under a tremendous amount of new stress, and just addressing that, she then started getting better again. So there's no question, these things have very clear impacts on our cognitive function.
Yeah, so trying to get into more of a parasympathetic state is beneficial.
Yeah.
Yeah, you might look into, there's a number of devices. I'm wearing something called the Apollo, which uses vibrations to put you into a parasympathetic state.
Interesting.
I'm finding that very effective for some of my patients.
Well, so let me ask you a question then, because one of the things I always worry about, people say, well, we're going to put you into this state or put you into that state. Well, if it's not the right state for me, I'm not sure I want to be put into that state. So, you want to have it appropriate. In other words, you don't want to be put into a parasympathetic state in the middle of shooting a gun you're in Iraq or something. You got to be careful.
Absolutely. So this device, they give you an app on your phone. There's a wake up mode. There's one for concentration and focus. There's one to relax. So
nice.
Different frequencies and intensity of vibration has a different effect. What do you think about peptides for reducing, preventing Alzheimer's? There's a number of peptides. Cerebral lysin, Selling.
Lysin, sure.
What do you think?
Thymosin, alpha-1, beta-4, all that sort of stuff. But I know Jill Carnahan has been very big about using these, and she's done a great job. So I actually think they're going to be one of the most important things going forward. And I think that especially intranasal administration, where you're really getting things into the brain, things like ADNP. There was a trial of a fragment of ADNP called davunitide a few years ago. And unfortunately, they did the trial as a monotherapy, nothing else. And no surprise, it was a negative trial. It didn't work. I think that that's one particular peptide. It's a tremendously neurotrophic peptide. Doing that in the right setting, I think, is going to be tremendously helpful. Same for nerve growth factor, same for BDNF, same for peptide fragments of these, same for things like cerebral lysin and thymosin alpha-1 and beta-4. So I think that these things can be very helpful. And I would put these very much, as I said earlier, pharmaceuticals are going to be helpful when used in an appropriate setting. But please remember to address the things that are actually causing the problem. That's the place to start.
What about stem cells?
Yeah, and so I actually just talked to a guy who today who just had given stem cells to someone yesterday, and we'll see how they do. Here's the thing about stem cells, and as you know, there are trials.
What type of stem cells and how did he administer them?
Yeah, these are the ADRCs, and this is with blood-brain barrier opening. This was actually done in LA. So here's the thing: the issue with giving these again as a monotherapy. It's like trying to rebuild a house as it's burning down. It doesn't make sense. So please stop the fire first, get all the appropriate things. Then I think for rebuilding the synapses that have been lost, because let's face it, by the time you have a diagnosis, you've lost a lot of synapses. And you need now initially these synapses become non-functional, but they're still anatomically present. But then you lose them, and then ultimately you lose the neurons themselves. So my argument would be, great, stem cells should be very, very helpful at the appropriate time with the appropriate treatment and the appropriate protocol. So we'll see. I think the data will tell us over the next several years.
So what is the best imaging for understanding whether neurons in the brain is growing or shrinking?
Yeah, great point. So there are several different ways to go. PET scanning has been the most helpful for telling you if you actually have Alzheimer's, because there's a signature on FDG PET, and then of course there's amyloid, and there's tau PET as well. So it's a very neurochemically oriented approach, and so that's helpful for diagnosis. However, for following, and what we did in the trial was to use MRI with volumetrics. So you want to have, whether you like NeuroQuant or you like NeuroReader, you want to have a computer-based algorithm to look at, do you have hippocampal atrophy? Do you have parietal lobe atrophy? Do you have frontal lobe atrophy, temporal lobe, these sorts of things, various regions of the brain. Do you have normal pressure hydrocephalus? Do you have big ventricles and no atrophy, that sort of thing. So that's helpful, but that doesn't tell you if you have Alzheimer's or not. You can infer that you probably have it. And I think, some people have argued we should quit talking about Alzheimer's, just talk about cognitive decline. It's all going to be related. And so you can argue that. I think I like having an idea of, is this Lewy body, is this Alzheimer's, because that simply tells you where you should focus more attention. If you have Lewy body, most likely you have toxin exposure. So you really want to focus more on that. If you have Alzheimer's, you're likely to have insulin resistance. You better focus on that and all the things we talked about for that. Each one is a little different. But again, you could look at just cognitive decline. So that's the second kind of imaging. Then, of course, there's this group Darmian, which is trying to look at, can we essentially infer a histology from looking at different regions of the brain. And that's going to be interesting. We'll see. It's early days, very little published about it. And so, lots of claims, not much in the way of publications yet. So I think it'll be very interesting to see. They may be correct, and maybe we'll see in the next few years some very striking outcomes with that, where we really can infer underlying pathology, which would be fantastic.
I know you prefer the Montreal Cognitive Assessment Tool for assessing patients with Alzheimer's, among other questionnaires. Is there a good questionnaire when patients have subjective cognitive impairment?
Yeah, this is such a good point, because you can use SLUMS, which is the St. Louis one, which is similar to the MoCA in terms of sensitivity. MMSE is another one that's been used over the years, but that one is not very sensitive at all. So that's really, each one has its own dynamic range. When you have someone who's got relatively severe dementia, you want the MMSE. The MoCA was developed specifically for MCI. But as you indicated, as we talked about earlier, you really want something that's hypersensitive for SCI, so that you can really catch people early and see if you can improve them. And I should mention parenthetically, we do have people coming in saying, I'm here for prevention, and they score 23 on the MoCA. They already have fairly significant MCI, and they're thinking they're there because it comes on so slowly. And so these people typically get right back to 30 when they do the right things. So I happen to like CNS vital signs, but there are others. There's Cogstate, there's Cambridge. We have used the CNS vital signs because you can do it over the internet. It only takes about 35 minutes or so. It's pretty easy. In fact, we even have a shorter version called CQ, which is easy to do. And it can really give you a pretty sensitive, much more so than MoCA scores, pretty sensitive indicator of where you stand cognitively. And also it does multiple domains.
Great. Awesome. Thank you so much, Dr. Bredesen. And we all thank you. Excellent presentation. We learned a lot. It was incredible.
Yeah, thanks for the invitation. Appreciate it. And look forward to hearing more great things. And I hope everybody out there will help to prevent and reverse cognitive decline. I think that's, this is the way that everything's headed. So thanks very much.
Yeah, we're all on that mission with you. Thank you, everybody. And we'll see you next month. Thank you, listeners, for making it all the way through this episode of the Rational Wellness Podcast. Please take a few minutes and go to Apple Podcasts and give us a 5-star ratings and review. That would really help us so more people can find us in their listing of health podcasts. I'd also like to let everybody know that I now have a few openings for new clients for nutritional consultations. If you're interested, please call my office in Santa Monica at 310-395-3111. That's 310-395-3111. And take one of the few openings we have now for a individual consultation for nutrition with Dr. Ben Weitz. Thank you and see you next week.